what kind of brought you into this field of EP and how did your career evolve?
Well, I think EP was a natural fit for me. As a biomedical engineer, I think, we wanted to solve problems, we wanted to figure out things, and that was super helpful. But I think engineering just wasn't enough. I think having the hands-on experience of actually being able to fix these things is what really drew me to the field. But it was definitely a natural fit for me. As you mentioned, I got my MBA along the way, which I think has been great because it allows me to speak a different language that I think a lot of physicians have not always been able to speak with hospital administrators, with purchasing, with service line, and figuring out, sort of basically not only how to make our patient outcomes great, but also make our hospital outcomes and efficiency and keeping profitable in the process.
I think it's an incredible function that you have in the hospital ecosystem because you do speak the language of many different areas and it's like you're a bridge. And so next question I have for you is in 2025, what should every non-EP person in a heart team in the cardiology space know, either from this meeting or just in general from your experience?
Yeah, I think there's been some really groundbreaking technology in ablation, obviously, particularly also obviously with left atrial appendage closure and combining those procedures. Traditionally our procedures have taken a long time. They've been hard to do. They haven't been particularly efficient. But that technology has changed. Pulse field ablation and other technologies have really improved our ability to give access to patients. The safety profile is tremendous. So we're doing ablations and offering rhythm control to patients that probably in the past we just wouldn't do. And then now also combining that with left atrial appendage closure, the ability to do concomitant procedures, the fact that these procedures are actually reimbursed and the hospitals can survive doing them allows us to basically offer therapy to so many more patients. And that's what we're seeing, and I think that's going to expand as we move on. And then eventually as we move on to ASC models, I think that's coming. And so we need to look ahead for that, and we as cardiologists need to be prepared for that. The referring cardiologist, the general cardiologist, the interventional and structural cardiologist, we're all going to need to work together to make that model work because, as you know, the hospitals have done really well traditionally, but we as physicians need to band together so we can protect our end too.
I think that's such an important message and it's very unique to your background, and I'm glad that we're able to share this with people because I do think that physicians have to be part of that conversation. Physicians do have to come together to make some of these novel models work in healthcare. Another question for you. So is there ever going to be a time when ablation is going to be a first-line therapy for AFib?
Yeah, I think we're seeing that now. We just completed the Avant-Garde study. We're looking at persistent AF, first-line treatment for AF randomized against antiarrhythmic drug therapy. I think we're going to see that's going to be a very positive trial. And I think, again, with pulse field ablation, with the safety profile, with the efficiency of the procedure, it's just so much easier to offer this therapy to patients earlier. Because we know about the toxicity of drugs, we know that they're ineffective. But in the past, we always did have limitations. There were always risks of procedures. But when that risk is minimized, like it is now, the risk of esophageal injury, the risk of phrenic nerve injury, the long-term bad complications that really made you hesitant to treat AF are pretty much gone. I mean, there's always going to be some complications with invasive procedures, but the fact that they are so much safer, efficient, predictable, we can schedule around, we can get them done in a very reasonable time. I think, we're just going to have greater and greater access. And like I said, as we move to outpatient models, we're going to be able to increase access to patients. And we as physicians need to be prepared for that. And we need to be at the table because we need to drive that discussion, not just have that handed to us by industry, by CMS, by hospitals. We need to be a part of these discussions.
So this is kind of an off-the-cuff question for my own interest. How do physicians who don't have the business background that you have learn more about these models and how we should integrate, and how do we learn more about this?
So I think this is a great segue. I'm actually leaving here shortly to do an HRA advocacy group. We are starting to increase. The physicians need to talk to each other because we understand each other's language. Some of us don't understand the language of hospital administration and of industry and of CMS, but some of us do, and I think that's where, again, we need to come together in advocacy groups and work together to go to these larger payers, these industry partners, and be able to speak as one to advocate for ourselves and for our patients.
Well, this is a very inspiring conversation. Outside of all of this, outside of the world of EP, what lights you up as a person? What do you do for fun?
Well, I happen to live in Charleston, South Carolina, which is probably one of the most desirable places to live in the country right now. So we have a lot to do. I mean, we have water, we have sun, we have golf, we have all that stuff. I'm a little embarrassed to say that pickleball is probably my favorite thing in the world, but I'm pretty good at it. So, we can get that going.
Great. So I'm inspired to learn about business and also to learn pickleball because I've never
Yes,
played.
that's great.
One last quick fire question for you. So what's your favorite EP procedure?
Oh, I would definitely say right now it's still a good garden variety complex PFA case. Like where where we have a nice atypical flutter, we can really show some electrophysiology, fix it, and move on. So we've been able to do it just so predictably, so safely that it's been able to treat so many more patients. Where in the past we may have given up. We may have said, look, we're just not going to fix this problem. So we're able to fix things that we couldn't before.
That's incredible. What is on your scrub cap in the lab?
Oh, I just wear one of those rad hats. I'm kind of boring. I'm boring, but I do have some
Is it
sweet.
patterned?
Listen, I have a sweet set of lead though. Even though I don't wear lead much because I'm mostly floralist, but when I have to wear lead, I have a nice all green. I'm a big tennis player, so we have it looks like Wimbledon. My sled looks like
amazing.
Wimbledon. Yeah.
Mine is actually like pink flamingos on the inside and unicorns on the outside.
Oh, I like
So,
it. I bet that's cute.
a little bit of personality. And then
Yes.
what is playing in your EP lab,
Oh,
music-wise?
I'm pretty robust. I'm anywhere from old school rap to country music. We do a lot of country. We live in Charleston, South Carolina, but we'll do rap. We'll do anything. And you know what? We'll do yacht rock. We'll do Backstreet Boys. We don't mind. We'll do it all.
Well, we loved getting to know you, and
Yeah.
we look forward to doing this again.
Awesome.
Thank you.